Welcome everyone to our first Zoom meeting. We're hoping this is going to be the first of many, and it's really nice to see some familiar names and faces on the call. I'm not going to say too much now before I hand over to Jason. Just on the wrong screen. No, wasn't. Oh yes. Right. Sorry, you should there be seeing what Zoom looks like on a PC, just in case there are some of you there that haven't used Zoom before. There's just some basic things. If you're looking at it on a PC, you'll see some controls at the bottom of your screen. If they're not appearing now, you can move your mouse or cursor down there, and they will pop up. And the important ones, we've got a left-hand corner. You can stop and start your video if you want us to see your faces. You can mute and unmute yourself, although we're starting with everybody muted. There's also a little chat box. If you notice there where it says chat, suggest you open. Proposal is that. Hang on, somebody's echoing. Who's echoing? Who's not muted? Proposal is that we take questions using the chat box. So if you think questions as you go along, type them in there, and every so often Jason is going to stop to take questions, and we can read out what's come through. And possibly at the end of the meeting, we might open up, unmute everybody, and then we can have a free for all, and anybody can join in. If you are on a, let me see, that should be wrong one. That's what it looks like on an iPad or tablet. Very similar, except you'll find that the controls are at the top rather than at the bottom. And another one I should have mentioned is there's a left here and at the top of the screen on the iPad, there's a thing where you can switch between speaker view and gallery view. So in gallery view, you see everybody's pictures. In speaker view, you just see the person who's currently speaking. So it's up to you really what you prefer, but I suggest you experiment with that and see how you get on. Now I'm going to hand over. Let me stop my sharing and hand over to Jason, who is now going to talk.
Welcome everyone. Well, I wanted to say, first of all, thank you, Gary, for, actually, first of all, I was going to ask if everyone can hear me, but I'm hoping everyone can. But you can put your thumbs, if you do the way of putting thumbs up and down that maybe Gary can keep an eye on. So if anyone has got a problem listening or hearing me, if they point to their ear, maybe Gary can see that. But I'm assuming everyone can hear me. So thank you very much, Gary, for inviting me for this, and also to Chris, who I've been engaged with in the past. My name is Jason Bacon. I'm Chief Executive of the St. Mark's Hospital Foundation and Academic Institute. And essentially, we look after the research that's conducted here at St. Mark's in the context of raising money for it. That's one of our main purposes. We also help facilitate the 34 research fellows that work alongside our clinicians. And we help look after them in terms of their, we certainly don't teach them, but we have a connection with Imperial, and they're doing their research quite often in the context of PhDs. And then we also run a number of courses. And so what you're experiencing here, we're also experimenting with moving some of our offline courses, the courses we used to host here and elsewhere, to be more interactive and have an online element. And we're at the sort of early stages of that development. I might mention that at the end, actually, because we've got 3 webcasts coming up, which may interest you. Actually, they're mostly for a clinical audience, but they're going to be free and open to anybody. So I will make sure that you are aware of those. And essentially the other side of what we do for St. Mark's, and you're part of this as well, the Red Lion Group. So St. Mark's is an extraordinarily strong brand with an incredible heritage. And I will talk a little bit about the clinical challenges now, but we also support the hospital, Omar, the clinical director, in helping him work out ways that the St. Mark's Hospital can deliver its expertise, its clinical care, not just here at the Trust, but in some of the other places that they are beginning to have to do that work. what I thought I would do, because I'm apt to just talk and talk, is probably break this up a little bit and spend about 20 minutes or so with just a background to what happened here at Northwood Park back in February, and how St Mark's was impacted, and the sort of things that happened around us. And then maybe open it up. And if you do have any questions, please feel free to type them into the message box, and Gary and I will pick those up. But also maybe we can open up to hear from some of you. We can have a little bit of a discussion and have some questions. And then I'll move on to sort of the here and now and what next, and focus on the clinical areas. I have to apologize. I won't be discussing anything specific in terms of pouch and pouch surgery, but I know you have another session with Janindra, and I believe one with Inspector Yoram as well coming up. So they'll be better positioned in terms of that area. I will say it's interesting. We've had some involvement in supporting the Red Lion Group in the past in terms of the Red Lion Day. We have the IBD Patient Panel Day. And those are always physical events we host here. And this is going to be a new way of working. I think you guys are paving the way. And I have told the IBD panel that this could be a good way for them to think about bringing their community together, because it's obviously very challenging in different ways to do things online. But having said that, getting a group of consultants together on one specific day every year is also very challenging. And I know that some of you know that all too well. And doing it this way, breaking it up into sections, actually is not a bad way to go. Right, so I'll stop waffling. So I thought I would just go back to, I've prepared it in the sense that I've given a couple of interviews on this subject, so hopefully I'll make sense and it will flow properly. But if I do miss anything, we can pick it up. But again, I apologize. Some of you may be well aware of what happened and how it happened. Certainly, we're all aware of the coronavirus crisis and COVID-19 that's impacting people, but certainly what happened here was very quick and very severe. That back in February, as we realized as a society that this virus was going to begin to impact, and people were going to pick up the virus, and it was beginning to happen in small numbers, we were one of the first centers. I don't know if you remember, but there were drive-through testings, and originally, if people had symptoms, they would call the NHS number, and if they could drive, they were asked to drive to centers to be tested. And we were one of those centers. It was like a drive-through. I don't like to be flippant, but it was literally like a drive-through McDonald's. So people would be coming through the other side of the Northwood Park site, and nursing teams would come out with protective gear and would swab the people in their cars as they sat there. They'd roll their windows up, and then they go home to self-isolate. And we were doing that in early February. So you could almost see what was happening, that more and more people were having symptoms and were being tested here. And then patients started arriving. Now, we at St Mark's, as you know, probably, hopefully some of you well know, we're a separate building, but we're physically attached to the Northwood Park Hospital. Northwood Park Hospital has a fairly well-known infectious disease unit and ward. So I think part of the answer as to why did a lot of patients with COVID end up at this hospital in quite high numbers early on was because of that unit. And I think we probably are a hospital that would have people come who were displaying some kind of infectious disease that was unknown. And that volume just continued. And I sit here in some of the managerial offices, so I sit alongside down the hallways is Omar Fairs and some of the other consultants are just across the way. And what we could see happening was our education rooms were being taken over for teaching, for our consultants, our surgeons, our gastroenterologists, physicians, our research fellows, to be relearning how to use ventilators. And it became obvious that what the trust was trying to do was to build up some capacity of knowledge that if they were needed to go into the wards and in ICU and treat patients, that there were more members of staff who could do that. And very quickly that happened. So very quickly our research fellows, our registrars, our consultants, and all staff, all clinical staff really, began to work on rotas in the hospital, both on the wards. A lot of the wards got reconfigured very quickly. The trust reacted quite quickly in terms of reconfiguring the site and setting up ward space for patients with coronavirus, and crucially ICU capacity, intensive care unit capacity. And so there were new wards set up for ICU. The theatres were also used at one point. I don't have the specific numbers to hand. I'm going to show you a little screen in a second, but the numbers got up to about well over 100 and 120 patients on wards with coronavirus, and then a percentage of them on respirators. So it was a very tough time for everybody, but I could always put myself in some of these, especially the junior doctors' mind. I mean, they've all signed up to be doctors and nurses, and that means treating people with who are ill. But obviously this is a completely different thing, and it happened very quickly. But I did see around me some incredible calls to action and people really stepping up. Very interesting anecdote. Some of the more senior consultants, physicians and surgeons, they were quite apprehensive about picking up, relearning the skills of needed for working with patients on ventilators. Whereas some of the junior doctors and some of the research fellows had their training maybe 2 or 3 years ago. Some of them didn't have that kind of training for quite a few decades. So in many respects, some of our junior doctors were helping our senior consultants with some of that knowledge. But in all cases, our staff were going into to work under experienced people in ICUs. So there were always plenty of experienced people, but they were there to support the staff in ICU whose job it is to look after patients. The anaesthetists were extremely important because of their nature of their work. They were an important they were important people to have around in the ICUs, and were working very hard. So it was very impactful. I don't want to dwell too much on it, but in terms of the foundation, we very quickly realized, we're a charity. We're actually a non-NHS charity, and we were set up many, many years ago to support St. Mark's. But we quickly realized that we're not going to be able to fundraise for research right now. Our educational courses, luckily we had already back in February begun to look at the risks of having large conferences here or courses here. So we were beginning to move some of those into the autumn or cancel them. We had a postgrad course running at the time with postgrad students from across the world. So they were beginning to be called back to their countries. So we had already planned the early stages of our change for education. So that was good. But we realized we had to do something else. So we were beginning to get a lot of offers of support from our traditional supporters, and we have some very interesting and strategic supporters of the foundation who support some very significant research here. And they approached us saying, what can we do? We'd like to donate money, we'd like to donate a help, and can we help you buy protective equipment? So we became a conduit for a lot of support that we were able to give to St. Mark's and Northwick Park and the Trust. And it was pretty successful. At the same time, we were extremely aware that we were already concerned about what other diseases and the diseases that we focus on, because we're a national center of excellence for IBD and cancer and all areas of work in upper GI. And we were about to start changing what we do and launch some massive COVID appeal. That was already going on everywhere. You're all very well aware of all the initiatives that have been there to raise money for the NHS. And however, we also couldn't be seen to do nothing. So I think we got it just about right. We responded to a couple of our clinicians, partners who work in the city, and they wanted to donate some fairly significant amounts of money. We had a corporate partner, a private equity firm, who actually wanted to do something very significant. They amongst their partners had met and had wanted to do something quite significant. And they thought the thing that they came up with is they wanted to approach a hospital. And the way they worded it was they wanted to adopt a hospital. They wanted to really strategically support a hospital during this crisis. And they had a relationship with St. Mark's already. They have been supporters of some of our research. And they said St. Mark's is who we want to support. And it became a very interesting project that still goes on to this time. And in fact, at 11:30 today, I have a call with them to discuss their support. But they funded some very significant, we bought some ventilated hoods, which are a very sophisticated PPE equipment. We did support with some basic PPE, some masks, some visors. We purchased things that were going to be gaps in the delivery of PPE. It was a very challenging time for our procurement teams. I think looking back on it, I would say that most of the time there was probably enough PPE in this country. It was probably just in the wrong place, and it was a huge logistical challenge that no one had really prepared for. And what we were able to do is provide material and equipment that was there during gaps in the normal process of procuring. And now we're talking about much more significant support in our clinical area, perhaps them investing and purchasing a mobile endoscopy unit and various other things they're supporting much more strategically. But for everyone, it was a period of change. We managed to get through this initial phase. I don't know if we should dwell on it too much. I might just share the screen quickly. It's probably not that easy to see unless I can. Gary, are you on? Are you off mute so that you can?
I've just unmuted myself. Yeah, I can see it now. Maybe make it a bit larger if you can.
Yeah, there it is.
There we go.
So,
that's fine. That's fine.
I'm sorry to dwell on deaths, but basically it's just a way of describing of showing you how this Northwick Park site was hit first. So these are the number of deaths and this is, I mean, a lot of patients who came very ill. Obviously, not everybody is dying, but obviously this shows the pattern of how many patients were here. And the grey line on the left that you see first appearing is the trust. So we were the trust that had the most patients, and not just this trust, but this hospital, Northwick Park and St. Mark's Northwick Park had the most patients from early March up until towards the end of March, when you see the blue line occur. I think the blue line is the Birmingham, is the University Hospitals in Birmingham in the Midlands, which you might have read about. They also had been hit quite hard. But that just shows you that we were hit quite hard. It also shows you the good news that everything a peak was hit around April in terms of deaths, and that was also, the same thing in terms of people showing up ill in hospitals has come right down. So I just thought I'd show that as just a visual representation of how we were affected. Am I off the screen now? Screen sharing is finished.
Your screen sharing has stopped. Yeah, we're seeing you.
So that really is what happened. Obviously, the clinical side of activity across hospitals across the UK have been severely impacted, and we weren't alone in that. One of the things that happened was some ICU staff and nurses on wards had symptoms, and there was a very strict, if you had any symptoms at all, you were forced to be at home and self-isolating for 14 days. Now, I'm pleased to say that most of those people were mildly ill, but they were following the guidelines. And what that meant was there was a shortage of staff. So that's when the peak of St. Mark's clinicians helping out was. Quite quickly after 2 weeks, most of those staff started coming back. And at the same time, patient numbers came down. So about 3 weeks ago, maybe even longer, probably 3 weeks ago, most of our clinicians have come off those rotas, and they haven't been working directly in the hospital looking after COVID. So then the challenge became is how to get back, and the backlog of the consultations and the procedures is what they're really trying to address now. I'll move on to that in a minute. I don't think I've missed anything specifically. I wondered if anyone had any questions about what happened here and how things panned out in the last 2 or 3 months. I'm more than happy to answer any questions.
Looking in the chat box, there's a few questions from David Davis. So maybe I'll unmute David. Where's he gone?
Can I just say, Gary, here I am failing miserably. I'm in the Zoom group chat. I can't see the questions. I'm in the wrong chat.
At the bottom of the screen, there's a chat symbol, and that opens the chat window. David's actually been sending his messages to me privately rather than to the whole.
Oh, sorry. All I can see is our chat. The last thing I can see is, "Hi guys, hope you're all well." Is that what? Is that the right one?
That's because David has been sending them privately. I think especially
that's fine. That's fine.
Want Jason to be able to see the question.
No, don't worry, Gary. You let me not interrupt. Yeah, that's fine. They can come through you. That's fine.
Okay, David, you're unmuted now. If you want to ask your question.
Great, thank you. Well, it's great to chat to you, Jason. Direct, so great. I've got some questions which you may be able to answer, you maybe not. Sorry if I embarrass you if you're not able to answer, but don't worry about that. But we've got plenty of people on the call who I assume have lots of good experiences, hopefully good, with working with or being treated by the people at St Mark's. And you've been very modest so far in terms of the role of the foundation. So my first question is, the foundation in terms of what it does in supporting the surgical teams and the activities and the research at St Mark's. What sort of pouch-related stuff do you get involved in, if any, in terms of the support that you provide to the teams at St Mark's?
So in terms of normally, or in terms of what we did in the last 2 or 3 months?
No, I'm thinking normally, generally. So for the people on the call who've got pouches, I think the COVID thing, I had a question about that, which was specific, which was...
Yeah, so, the answer to your question is, we're really here, it's 3 things. It's the support for their research, and that comes in 2 guises. It's the money we are able to raise to fund research, and also it's the support of facilitating the research fellows. Because a research fellow will show up as a junior doctor and will often be working either on call to fund part of their salaries, or will be conducting research and will require a grant, medical grant, or funds that we were able to raise. But they also need support in other ways in terms of their work and their interactions with Imperial, that the clinicians can sometimes not directly help with. So we sort of support the clinicians in managing a research function. It's called the St Mark's Academic Institute. It's a very strong brand, but it is a virtual brand. The St Mark's Academic Institute is a key part of the hospital, but its operational engine is the charity. It's part of our team. My team is split up into 2. It's people looking after education, the research fellows, and then it's people looking after fundraising for the activity. So yeah, we support in that way, and then we also facilitate the education. So we have a number of courses. Our biggest one is called Frontiers, and again, we facilitate the delivery of our education. We're not the faculty. The faculty, when I first joined, actually, I'd been here about 3 months. I kept hearing people talk about the faculty, and I thought there might be some other building somewhere where this group of faculty live. And then someone pointed out, so Jason, the faculty are basically the same consultants. This is the way I've described it to funders, is our consultants and our specialist nurse teams as well. They put on, they're clinicians. That's what they do. They're doctors, they're nurses, they're treating patients. But then they put on their research hat, and they're researchers, and they're conducting research with the research fellows under them. Then they put on another hat, and they're faculty all of a sudden, and they're teaching people from all around the world. So we pretty much hold that glue together and help deliver it, is what we do. Yeah.
Can I ask another question, please, Gary, if I may? The work that's done at St Mark's, and in terms of going out to the communities to raise money, how well is the St Mark's known, and how well is the sort of pioneering work that they've done? In our case, it's for the pouch operation, but there'll be lots of other examples where I guess their work is leading many fields. How well is it known out there in your donor communities?
Wow, that's a great question. It's probably one of our biggest challenges. I think the short answer is it's not well known enough, frankly. I think in the medical world, it is well known. Certainly in the gastroenterology, upper GI, colorectal cancer, IBD, family cancer, intestinal failure, any number of areas. It is very well known and very well respected. There's a hospital in China that calls itself the St. Mark's of China. And that's how they refer to them. So I don't think they have it. If they had it on their building, I'd ask for them for some money. But they, it's very well respected, very well known. I think outside of this area of medicine, it's even within the medical community, it's probably not well known enough. When I talk to funders and people who haven't heard of St. Mark's, I say, we are to bottoms and bowels what Great Ormond Street is for children, frankly. But part of our challenge is to raise the awareness. Now, the other side of that is for patients who have been treated here or have been treated by St. Mark's clinicians elsewhere, that it is obviously not just well known, but there's sort of a deep relationship. And I said that within the patient community, of course, it's well known. There are interesting facets to that. So about 60% of the patients who come to St. Mark's and are treated here come from outside of the area. They're referred with, I guess the term is tertiary referrals, and the rest are the local community. And our community fundraising is an important aspect of what we do, but it can't be the only focus. We have to be national. I will, part of what we do when we fundraise is to talk about the here and now and talk about what's happening in terms of our research and what our objectives are for our research projects. But we have an amazing legacy to be able to present a credible argument as to why you should give us money. And I don't know if any of you receive some of our material, but 40 years of innovation at St. Mark's was our campaign. We always have a campaign at the end of the year. And the pouch surgery in 78, Flex, which is a procedure for endoscopy, the taser is taser Flex, before we even get to robotic laparoscopic surgery. The innovations that have been developed here are phenomenal. So that gives us a foundation to go out there with. But it's a never-ending challenge to be able to articulate to an audience on what we're doing and why we're doing it and why it's important.
Fantastic answer. And do you know, and you may know this, you may not, but are the number of pouch procedures increasing at St. Mark's? Is the pouch team, is the people who do the pouches, that group expanding, or is it staying the same, or
so you will test my knowledge here, so you can definitely test this out with Janindra. It is I think the answer it is increasing. From my point of view, I'm fairly close to some of the background data on things like all kinds of procedures like complex cancer and such. But with pouch, I'm pretty certain that maybe a while ago, I don't know if it's decades or 10 years ago or 20 years ago, you might have one surgeon who is renowned for the pouches. You've now got many, you've got 3 or 4 now.
Yeah.
I think it was about last summer, we did our first, I think we were the first in the world to do a pouch surgical procedure using the robotic Da Vinci laparoscopic tool. Yeah. So even Danilo, so the answer is there are more. I think you guys know better than I do. There's always that dynamic of pouch versus stoma. What journey is someone on in the disease management and the pros and cons. I will say that, and that's definitely something for Janindra, not for me. But I think that from what I can see, and I attend, we have something called Grand Rounds every Friday where I come in early, but for me, it's a great way to learn what's gone on in the past and what's going on now clinically. I don't need to know I need to know enough about clinical work to be dangerous, but I'm fascinated by it, so I always want to know more and more. This is a fairly obvious thing to say, but as disease management gets more and more sophisticated, and there are more and more medicines, there are more and more treatment options, more and more surgical procedures. If you think of endoscopy, not long ago it was purely a diagnostic tool to have a look up there to see if there's anything there that needs to be treated surgically. It's, to me, and I'm not from a medical background, when I started talking to the endoscopists when I first joined and they were telling me what they did, I said, why aren't you you're like this is a surgical procedure, surely. And they laughed at me saying, go tell the surgeons that. But yeah, so the answer is there's more complexity, which means for patient choice, the patient choice has always been talked about, involving patients in clinical pathways and decision-making, which has probably always been important since day one in medicine and healthcare. It's not even important now. There's no choice. The clinicians have no choice because there are so many different ways to look at disease management, so many different options, and it's good news that there are. but it does make it complex in terms of avenues and pathways and delaying certain procedures and trying out certain things. And again, it's good news, but it just means it's more challenging there's never a right or wrong answer in treatment. So I think pouch is part of that discussion in all aspects of what we do here.
Yeah. I mean, Linda made a very important point about centralization of specialist services such as pouch surgery. And just reflecting on that, there was a fascinating survey by the Association of Coloproctologists, which is probably the biggest UK-based survey that's been produced of pouch procedures and outcomes. And that was published in 2017. And one of their key recommendations was that such specialist surgery, requiring not just the expertise to do the surgery, but the support functions to be able to support the patient before and after, should be centralized into a small number of select sites in the UK. And that's reflecting, I think, on Linda's comment. And I mean, St Mark's, you mentioned it was a centre of excellence, and I think it's worth reflecting on that. And I'd be very interested to hear your thoughts on centralisation.
So David and Linda, you've very nicely segued into the second part of the discussion, because that is thank you. No, and Linda, thank you for that question. That is a fundamentally important question that applies to everything that we do here now. And it's pouch surgery, yes. I mean, the skill sets, and I think you mentioned, Gary, David there, the aspect. It's not just the surgeon, but it's the whole team around it, and the pre and during and after care. And we kind of loosely bandied these terms, specialist nursing teams. You know, the specialist nursing teams are critically important part of St Mark's. You know, just some of them: the IBD team, pouch, stoma care, complex cancer team run by Claire Taylor. So you can't really replicate that in a lot of different hospitals. So you inevitably, that's sort of an infrastructure that's best suited to be in one place. You're absolutely right. However, there's always the balance of not having something available only in one place, because there's always capacities around that in terms of how many people you can treat particular procedure, quite apart from travel and other challenges. And that's a discussion and a balance that's it's been going on for a long time. The challenge we have now, it could be an opportunity. So it's obviously public knowledge that managing other non-COVID diseases has been, you can use words, put on hold. It's been dramatically impacted, restricted, whatever you want to say, but no one's going to deny that it has not been impacted. And I won't get into the pros and cons of approaches by the NHS or the government. I have my own views on managing risk and managing disease risk, but I'm not going to talk about that right now. But I will say that right now, a huge amount of focus is going on at a national and sector level on where you now clear backlogs and bring clinical activity back and back safely. I'll talk a little bit about surgery in a second. Actually, there's interesting things going on there. What's happening, and you're probably well aware of this with your families, with your work colleagues, with your reading the newspapers. This is impacting all industries and sectors, and non-healthcare as well. And a lot has been written about how change that might have happened over 5 years, 10 years might happen in over 1 year, or in some cases even shorter term. And what seems to be going on now is a more strategic look at how clinical services are delivered at a sector level, and trust. Some of our frustrations we've had in the last few weeks with our trust has been the seeming lack of decision making. But what we quickly realized was they weren't making the decisions. It was happening at regional and sector level. And sort of for the here and now, talking about the next few months, the obvious thing to be doing is to do as much clinical treatment as you can as safely as possible, So work out where are you going to look after COVID patients, where are you going to bring back clinical services that won't be impacted if more COVID patients show up again. People talk about second waves, and who knows if there's a gradual increase, or hospitals just have to get used to patients coming with COVID. But you certainly have to build capacity for your normal clinical services. And right now where we speak, I'll give you a snapshot. We have endoscopy, and this is not necessarily a bad thing, but right now we've got endoscopy going on in 4 places: at St Mark's here at the Wolfson, at Ealing, Central Middlesex, and the Clementine Churchill, which is the private hospital around the corner. Benign surgery is taking place at the Clementine Churchill, and cancer surgery is taking place at the Marsden. These are our clinicians. So everything I've mentioned is some our clinicians doing their procedures in these places. And there's all kinds of scenario planning on how we continue to build up that capacity, but where do you build it? At the same time, the sector is looking at, okay, how much of this is maybe longer term? Maybe we need to think differently about, integrated healthcare. So there are challenges and opportunities for St Mark's and how it develops its clinical services. And maybe they're not all restricted to one building, because there've been always a lot of challenges of having this specialist hospital sitting here next to this massive A&E hospital. And all kinds of challenges around that, and they're even harder now. So that centralization versus localization, I think skill sets and ways of doing things need to be exported. About a year ago, I heard about Dr. Warren Heyer, who's the pediatric gastroenterologist at St Mark's. He does a lot of work at the Chelsea and Westminster Hospital, has a clinic there as well. Apparently he was recognized by NHS London, I think it was at the time, on how the multidisciplinary approach to treating his patients was actually the right way to do it, and had clinical outcomes far better than other kids. And he was asked by NHS London to look at ways they could replicate that in other hospitals. And I said to him, that's one of the challenges Marks has, is representing its multidisciplinary approach. This is what you've described, David. You've got specialist nurse teams and surgeons and gastroenterologists. And I've had patients describe it to me. They say, I couldn't believe it. I was in a room and I met with, the nurse specialist before my procedure, afterwards, the oncologist, the surgeon, all together. And they described multidisciplinary medicine. So my point about Warren is, I said to Warren, that's great. We should be recognized, for our adult care. We should be recognized too, or we should try and latch onto that and make sure that NHS London looks at it not just for pediatrics. And his answer was, you already do that up at St Mark's. So we already do that. So what's the problem? Well, the problem is we're not recognized for it. The problem is the trust doesn't get the income associated with doing these treatments this way because of the way the NHS works with commissioning groups. So I'm straying a bit here, sorry, but all those challenges are being looked at now, and maybe there will be some, I hasten to use the word fundamental reform, but certainly the way the NHS has to plan now for clinical work in this era, in this time, and who knows if it's another 2 months, 3 months, 6 months, whatever, could be more fundamental than just the short term. And our challenge is to be part of that conversation, which is what Omar and a lot of the senior clinicians, and I would say the trust as well, is supporting. And part of that is, where do you centralize clinical delivery, and do you have other sites as well? Because right now, centralization doesn't make sense if you've got 3 of the world's best pouch surgeons sitting in a site where they can't operate. Because back to the status, there's no elective surgery happening here in the theatres at Northbrook Park. So right now, it makes sense for them to do those procedures somewhere else. Otherwise, they can't do them at all.
You muted, Gary.
There's a couple of questions that come through. I wonder if you would take these. One is from Elaine. Elaine, do you want me to unmute you and you can put the question yourself?
Yes.
Okay, you're unmuted now. So over to
Hi,
you.
Elaine.
Oh, hello. My question is that I have FAP in the family. My mother, myself, my sister, and my daughter. My mother, myself, and my sister have had our bowels removed. I have a pouch. My daughter's was diagnosed at 15. It's a verified form. It's not an aggressive form. And when she was diagnosed at 15, they thought at that time, she's now 31, that there might be something that could stop these polyps becoming cancer by the time she got to her 40s. Is the research going on at St Mark's into FAP at all?
There is certainly a lot of research in familial polyposis. I'm not aware of how close we are to getting to a stage where we can stop a polyp becoming a cancer, but you know, that's I'll double check that one. There's certainly a lot of research going on there in terms of all of the genetics behind polyp development, and a much more sophisticated view on being able to understand the likelihood of them and the timing of them, and obviously critically removing them appropriately. Of course, that's a big challenge when you're developing so many, when someone is developing so many of them. But there's a lot of research going on genetics, and the balance of genetics and environment as well, into more understanding of polyp development. And no doubt at some point there will be much more, some kind of a leap in that knowledge, and some kind of a significant milestone in being able to fundamentally treat polyps and stop them developing in the first place. But I don't know that specific research. Obviously, Professor Clark, you know well, she oversees all the research in the family cancer unit.
Okay, a question from Judith Whitaker. I'm going to unmute you, Judith.
Okay. My question is there a sort of specific risk to people with pouch patients from coronavirus? I had a pouch surgery 25 years ago after 35 years of ulcerative colitis. I am particularly at risk because I'm over 70, but am I also particularly at risk because of either the pouch surgery or the previous ulcerative colitis?
So I'm going to have to be very honest with you, and I don't know is going to be my answer because I'm not clinical, but I'm not going to just leave it at that. First of all, and Ben, the previous question as well, you know, Janindra will be the right person to ask these questions to, and I'm glad that he's doing one of these. And if I was the only one, it wouldn't be very useful. And I'm glad I'm on first, actually, because maybe, you know, he can give a context from his point of view of what happened over here the last few months, but actually more importantly could talk about these matters. There is risk for surgery now. So for someone who was about to have surgery, there are all kinds of challenges and risks going on. From my understanding, the primary risk factor for putting someone into a vulnerable category is related to immune system. So it'll depend on people's any medicines people are taking for that affects their immune system. There's a lot of research going on that, and in fact, some of our IBD research now is beginning to is not stopping, but it's actually evolving to look at some of those factors. So that's the main factor. Apart from the obvious, which I'm sure we've all read about. I mean, hypertension, obesity, kidney disease, anyone who's had those are areas, but I'm not fully aware of any specific risk. But then again, I'm not the right person to ask. Janindra would certainly have a view, but I think everyone, even scientists and doctors, are learning because it's a new virus. So any opinion, any medical insight on that answer would always be caveated with in terms, you know, how they might learn more.
Thank you for that. Question from me. I hear imperial colleges mentioned quite a lot in context of the foundation. Can you say something about the special relationship between yourselves and Imperial, if there is one?
Yeah, there is one. I mean, we call it our education partner. So we don't bestow BScs or PhDs with our fellows, and they get those from, I don't know if they get them all from Imperial. I think some are from UCL, but most of them, the vast majority are from Imperial. So we have the education relationship is that our our research fellows will have a tutor, a sort of academic tutor at Imperial, and they will be delivering a PhD dissertation, and the research they are doing for that dissertation is with the St. Mark's consultants and patient groups here. So that's the relationship primarily. It's around the education side. And to be quite honest, on our research, we also collaborate. What we bring to the table with research is fairly obvious. We bring clinical expertise, and we bring large scales of patient groups in all kinds of areas of disease. And so we partner with the Bart's Cancer Institute, Imperial, UCL, a lot of different people with labs. We don't have 10 floors of laboratories here, which is actually fine. But we do partner with people who do have those facilities, and they like to partner with us because of what we can bring to the table. So most of our research is collaborative, and our education is collaborative in the sense that the PhDs are bestowed by Imperial.
Thank you very much for that. We'll let you carry on with your talk now, I think, unless there's any other. People can unmute themselves as well, actually. So if anybody has a question they would like to ask at this stage before Jason continues, you can unmute.
I'm just looking at, Darren has answered that question much better than me, that the British Gastroenterology Society has published a detailed list of vulnerability conditions and classes available on Crohn's and Colitis UK website. The CCUK have produced a lot of material on that. I think there is an interesting piece, which is low immunity is not obviously is a risk factor, but of course a lot of diseases are because of a hyperactive immune system. And so it's not as simple as having low immunity is going to be a more risk factor. And then this virus is so complex, and they're still learning about it. People still don't know why some very healthy people, young people with no preconditions, get extremely ill and sometimes very occasionally die. And yet others who are exactly like them get coronavirus with no symptoms. Not even, forget about feeling mildly, or they have no symptoms. So that's a big question, what's going on there.
If I can just add a comment, I'm an admin on the J-Pouch Facebook interest group. I'm not speaking with any detailed specialist knowledge on this at all, but the consensus has been on discussions to exactly Judith's question, that it's not the pouch per se that induces the risk in pouch people, it's the immunotherapies that they may be on, particularly for suppression of pouchitis. As Darren mentioned, the Crohn's and Colitis UK site has an extremely good risk. It's a flow chart for risk, which gives you a very good indication of what your risk might be. And it also provides some detail on the drugs, the specific drugs that people may be on, and how that can impact their general immunity. And presumably there's an implied risk to coronavirus from that. So let me just say I'm not an expert, so please don't take my comments as gospel. But if you look at some of the chats on the Facebook group for the J-Pouch UK specific, you'll see quite a bit of correspondence on that very good question.
I'd also say, when you do speak to clinicians or have the opportunities to, and you will with Janindra, is always ask the question, why? Because if he makes a statement like that about immunosuppressant drugs, it might sound obvious, because if your immune system is suppressed, you're more. But actually, it's not obvious with COVID-19. Always ask why, because it's not yet obvious. So I'll give you an example that's been going on with surgery. So at some point about a month ago, there was a perceived risk, or a risk, of laparoscopic surgery of all types, robotic or just traditional laparoscopic. When the patient's abdomen is inflated, that is under pressure, and then there's an aerosol risk, and the potential risk for spreading coronavirus, and theatre staff would be at risk. And so therefore, laparoscopy is more dangerous than open surgery. Let's go back to open surgery. Now, our laparoscopic surgeons, frankly went ballistic, and it really just ended up being someone was louder than others early on, and suddenly things went down a path that didn't make any sense. There were ways to make laparoscopic surgery safer. So I think it's very unsettling to hear this, but informed scientific and informed medical opinion is hugely important. But the information is changing so frequently that it's always good to get other thoughts and opinions from elsewhere and ask people why something leads to a higher risk. Because certainly this, anyone over 70 is more at risk than people who are younger. Well, sort of, but then, you could say anyone over the age of 20 is more at risk, because that's a fact. So, and some people over the age of 70 are much less risk than other people below who might have, obesity at age 20. So, a lot of these things you need to have these frameworks. You need to have ways of managing everything, but it's really important to, I've seen in 2 weeks, 3 weeks changes in terms of what's been planned and what's known, because frankly, the information keeps changing. I'm sorry that sounds unsettling, but in many respects it might not be, because you might be told that you're at risk and this is dangerous and that's dangerous, but that doesn't mean it'll always, there might be new insight that comes out that lowers that risk. Sorry, I don't know if that makes sense, but.
Thank you for that. Do we have any other questions from other attendees at the moment?
By the way, sorry, I've noticed I'm not looking at my cameras because I'm on a laptop here, but my screen is over there. So I apologize if I look like I'm looking away in the distance.
So David, do you want to come in and talk about our next meeting?
Well, I'm delighted to do so. Thank you. And first of all, thank you very much for Jason. That was fantastic. Really great. Thank you. And
well, no, I'm glad to join. I'm sorry to interrupt. I probably should step away so I don't interrupt any further to prepare for my call. So thank you very much for inviting me. And I'm always there to help. Chris has been great. And if you need any help, I think you've got these other two planned, but if there's any problems with those, or if you want to do others, I do see these clinicians quite frequently, so I'm more than happy to remind them.
Fantastic. Well, thank you again from everyone. We've actually gained one since you started, so we're ending up with more people at the end of your talk than at the beginning. So that is unique in my experience of these recent webinars. So well done, and thank you very much for all your knowledge.
Thank you all again, and very good. And
thank you.
Okay, great. And just generally to speak to everybody else, I mean, clearly Jason isn't a clinician, so he was constrained by some of the questions that we had for him. I thought he handled them very well, may I say. But we've got two fantastic opportunities coming up for you in terms of webinars coming up in the next 2 weeks. So next Thursday, the 28th of May, make a note in your diaries, please. We've got Janindra Warusavitani, with apologies to him for my pronunciation of his surname. But Janindra, let's be under no illusion, is one of the world's top surgeons in colorectal diseases, and in particular in surgery as a result of inflammatory bowel disease. So he is one of the world's leading pouch surgeons and is right at the forefront of the work being done at St. Mark's, where he's a consultant colorectal surgeon. So Janindra will be speaking to us this time next week, 10:30 to 11:30. Please make a note in your diaries. And Gary will be sending out the login details as he did for this webinar. And then the week after, we've got Dr. Yoram Inspector, who is a consultant psychiatrist and head of the psychology medical unit at St. Mark's Hospital. Now, some of you may have had the privilege, as we did, of hearing Dr. Inspector speak at an information day. I think it was now 2 or 3 years ago now at St. Mark's, and he received the top review scores of any speaker we've had at any of the information days that I'm aware of. So a really fascinating insight from Dr. Inspector into the psychology and the challenges of psychology, impacts of diseases of the gut. So Yoram will be speaking to us again on the webinar Zoom format on the 4th of June. So that's a week after Janindra's talk, 4th of June, 10:30 to 11:30. So two absolutely outstanding speakers lined up for you. And thanks go in no uncertain terms to Christopher Brown, who's one of the trustees of the Red Line Group and who's lined up these two great speakers. And we're hoping to add to that list indeed in the future for you. So please make notes in your diary. Please join us for what I think will be excellent talks, and perhaps a little bit more relevant clinical knowledge for you to ask your questions and be able to get some real insightful answers. So thank you. And thank you also to Gary for setting it up. Back to you, Gaz.
Thanks for that, David. Well, I think we're actually, another first is actually, I think we're going to finish slightly ahead of schedule, but unless there's anything else anybody would like to say, if you use the...
Gary, there was one comment from Linda about the secure IBD database. I can see Linda's on the call. Linda, do you want to unmute yourself and give us a bit more information about that?
I actually should have looked it up before I came on, but yeah, there's from all around the world, the consultants, I think even patient can do it, but consultants can put in, if their patient has a history of IBD and contract COVID, then they can put it into the database. So I think they're still getting data, and I think from that, in the next weeks or whatever, it'll all come together and say, see what the results are. I know there's definitely, obviously, steroids are a risk factor. Obviously, I think they found biologics and stuff wasn't quite as high, but then there's different reasons. Maybe they're self-isolating anyway, and they weren't exposed. So there was something about Fantasia as well, but I think they're still collating all the data. So it'll be interesting to see what comes out of that.
And I mean, I noticed that there's 59 UK IBD related or patients have been reported as having had COVID. One thing's for dead certain, as you mentioned there, we're at a very early stage here of analysing the information from the disease in terms of who gets it and why they're susceptible, why they're not susceptible. And I think this sort of database is fascinating. I was completely unaware of this. And it's good to see that this sort of information is being collated, because this is the sort of information down the line that will give experts the opportunities to see where the relative susceptibilities are. But I have to say that number seems to me very low at the moment, 59, given that there's at least 10,000 pouch patients in the UK. And obviously this is all the people with inflammatory bowel disease. So obviously it's early days, and obviously this data has to be completed. But I think it's very encouraging that it's being collected.
I think it just gives you the idea that you just be careful anyway. So do your precautions. Be careful. Stay safe.
David, I'll let you have the final word.
Oh, well, thank you. Thanks very much. I think we're just about on time, aren't we? Fantastic, bang on. Listen, have a good week. Stay safe, everybody. Thanks to Gary for setting it up. Thanks for Chris for persuading the speaker today, Jason, to speak. But thanks all for attending, and look forward to seeing you next week for Janindra's fascinating talk. Have a good week.
Thank you.
Thank you all.